right. Well, welcome everyone. Thanks for joining us tonight, and thank you for welcoming me into your homes, or your cars, or your phones, or wherever you're gutting out this COVID crisis. And I hope everyone is staying safe and healthy and appropriately socially distancing. I know we've been struggling here, but I think the staff and everyone has done very well trying to deal with this and make sure we have everyone with access to healthcare and really trying to keep things moving forward. In any case, I'm going to talk today about some of the changes and some of the treatments we have for hip and knee arthritis, and focus a bit on total hip and knee arthroplasty we're not getting advancement. We're going to have a little technical problem, but here we go. As Sarah said, I'm David Markel. I'm the market president for the Cort Institute in Michigan. I also run the residency program in the laboratory at Providence Hospital. I've been doing this for quite some time. These are my disclosures, not really relevant to the talk, but in orthopedics, we like to put these out to show that if people have any biases or potential conflicts in the things that we're talking about. My practice has been based at Providence and here with the Cort Institute for basically my whole entire career since '94. I joined Charlie Peretta, and he started here over 60 years ago. So we've had a long-standing relationship with Southeastern Michigan, and we've had a long-standing relationship with Providence as well as other hospitals in the region, trying to promote musculoskeletal health for all of our patients. I'm going to talk to you about hip and knee arthritis, which is really the vast majority of my practice. As you can see from the slides, excuse me, on the my left, so that may be your right, I can't tell, of the screen, arthritis really is loss of a joint space. So when you look at the slide on the top right, you can see two knees, you can see a nice space between the bones, and the slide on the left, you can see that the bone is touching the bone and is fully eroded. You're seeing the same thing with the hip below that, and on those pictures on the bottom are showing the inside of a knee, and you can see the cartilage is all worn away, and inside of a hip that's been removed, and you can see the white stuff, which is the cartilage, is fully gone. And this is the problem that we're dealing with. When we have arthritis, most of it's mechanical. And so with mechanical changes, we wear out the cartilage, but that creates a inflammatory response, which is very biologic. And this is the sort of thing that we study in our laboratory. There are things called collagenase and gelatinase, which are destructive enzymes that will break down cartilage, and there's fluid in the knee that helps nourish the knee and helps protect the knee over time. And the HA, which is hyaluronic acid, is something we'll talk about in a little bit. Here's a picture on the left-hand side. That blue is cartilage, and you can see how pretty it looks. You can see layers of cartilage and cartilage cells going down into bone. The part in the middle, which is a rift, is something that I created. This is actually a specimen from our laboratory where we're doing some cartilage research, and we cut through that, seeing if we could get the cartilage to heal. What we know is cartilage doesn't really heal. So over time, because of the factors that you see in text, what happens, the cartilage slowly wears away, and ultimately you have a picture like the bottom right, where you can see the white part of the cartilage fading away until just what you see is bone. And having bone seen inside the knee is bad, because that means all the cartilage is gone, and the cartilage is really the bearing surface of the joint. Well, why do we talk about this so much? We talk about it because osteoarthritis has an incredible need in our country. The medical cost is billions of dollars a year. There's more patients treated in the 2000s than ever before. There's a morbidity from taking anti-inflammatories and other drugs with GI problems and kidney problems, and people are getting afraid to take these drugs regularly. When you talk about the Arthritis Foundation, really a fabulous organization, they have statistics like you're seeing here, where 33% of the people with arthritis have work limitations, leads to a high cause of disability. 65% of patients under 65 are having problems. And this has led to having almost 1 million joint replacements a year in the United States. So I'm going to talk about knee arthritis to start, and we'll follow up with hips. Right now, it's at least 1% of the population in what would be a young age. So I'm talking about people 55 to 64. In the past, we didn't really like to talk about arthritis in people less than 65. Males, a little bit less than females. probably because women work harder and more active. And you can see from the top two pictures again, a normal knee with a nice space between the two bones, and on the right side, the arthritic knee, where you can see the bone is touching the bone. And that's from erosion of the cartilage, which actually creates that space. Two different patterns of knee arthritis. One is knock-kneed, which we call valgus. One is bow-legged, which we call varus. The bow-legged is more common. It tends to be painful. It tends to swell. It tends to hurt quite a bit, cause stiffness. The knock-knee pattern tends to be a little bit more mechanical sound in that it doesn't cause as much pain often, but people usually complain that it feels stiff, it feels tired, and often it doesn't feel stable when they're walking. And often the biggest complaint people with knock-knees are, I don't trust my knee, and the not trusting the knee tends to be worse than the pain. Well, what do we do to help protect your knee early on? Well, we try rest and exercise. Definitely using ambulatory aids and therapy are helpful. I'm not against things like chondroitin sulfate and capsaicin, the topicals. Really, if there's anything that helps you, that's not very expensive, it makes you feel good, and it doesn't cause you harm, I'm all for it, as are most of us. Physical therapy, I think, is very important. I think therapy helps get us moving. It helps show us how we can exercise in ways that doesn't cause pain. And you can see the picture on the right where there's some walking sticks. And I encourage my patients to get these walking sticks because you can use sticks like that. You can go for longer heights. It unloads the knee, and it doesn't look like you're using a cane. And those are widely available, and I would encourage all of you to try to use that over time. It'll also keep you from falling down. Some of our more traditional treatments would be using anti-inflammatories. I take Advil several times a week, but I'm not advocating for them. Celebrex, here's a brace, that's a fancy brace. And sometimes people will think that operating on a knee with a scope is effective, but we know that arthroscopy for arthritis doesn't work, and I'll show you some pictures of that in a minute. Steroids, a very common early intervention. Unfortunately, you need to do this with an injection. It's relatively safe. It can be done with or without ultrasound. It definitely decreases inflammation, so it's sort of like putting a strong amount of Advil into the knee directly. You probably don't really want to be doing this more than every 3 months, and you need to be careful with people who are diabetic because you can get a bump in your sugar. Sometimes it can hurt, but I think with a skilled provider, the injections aren't too painful. I think a key thing to remember is if you're thinking about having an operation, you do not want a needle in your knee within 90 days of surgery because we've learned from large data sets that can cause an increased rate of infection. How about the gel shots people talk about? They've been around for a long time, probably from the 40s. They were first used in the racehorse industry. My wife owns one horse, my daughter a horse. And early on, I thought it was crazy, but the veterinary people were giving these injections. And I got to tell you, if you have a lame horse or a dog with pain and you give them hyaluronic acid or chondroitin, if the animal responds, they have no reason to try to dupe anybody. So there's certainly clinical evidence that these things are effective. It's been very, very hard to prove this in the laboratory. We've done several studies on our own, and trying to find the mechanism of an action is very difficult. That being said, if you try the series of shots and it helps, that's great. You don't want to repeat that insurance won't let you do it more than twice a year, but you really want to get at least 6 months of relief before it's worth doing anything. We're getting a lot of questions right now about stem cells. There are a number of different stem cell preparations. The reason for that is different companies and different industries are really promoting them. I worry about that because a lot of these are cash-based industries, and I think that cash on the table always makes things difficult. There's a lot of marketing out there. What I will say is we don't really know the outcome of this. What I can tell you is there is no evidence in any trial that putting anything in your knee is going to grow back your cartilage. Now, there are certainly several different studies that show having injections of these materials may help your pain, which is a little bit different thing. So you have to weigh what treatments are available, what things help. You certainly got to weigh in what the costs are, but I'd be very careful about any promises that people are giving you relative to outcomes. I would say generally right now, if people with advancing arthritis, we don't do that great a job. We have a lot of things that we try, but once you get to the point with bone on bone or significant arthritis, we don't really have a good job. Most of what we do is reactive. Arthroscopy will not work for a knee arthritis. If you have a torn meniscus that's getting caught, you can sometimes help the mechanical symptoms, but you can imagine, like a picture on the bottom right, once you're showing exposed bone like that, cleaning that up doesn't change the mechanics of the knee. So that takes us to joint replacement. Unfortunately, that's an operation, but we have some very defined goals. We want to help your pain. We want to restore your motion. We want to definitely help your stability so you don't fall down. And we want to give you functional improvements so that you're happy in the long term. I'm going to start with partial knees. That's not really the focus of the talk today, but a partial knee is basically if your arthritis is only in one part of the knee, just the inside part or the outside part or even the kneecap, sometimes we can just replace that particular area and resolve most of the problem. It's a little bit of an easier operation. It's a little bit faster recovery, tends to have a little bit better motion and stair climbing ability, but we want to make sure that you're a specific class of people that fits that, because it only works if you're someone who fits in that little box of a partial. The third slide there is a picture of a CT scan. Many people are doing partials with the robot right now, and something we'll talk about in a little bit. Yep. Sorry. Total knees, probably 650,000 total knees done a year right now. Very popular operation, and it's popular because they last a long time. At least 95% should last at least 15 years. I think at this point we might knock that up to 20 years. Once you make it past the first couple of years, it should last you a very long time. 95% of people who have the operation are happy, and we're starting to push this into younger and younger populations. The 50 to 65 year age group is the largest growth population that we have for total knees. Just an example of a knee flexing, extending, and you'll see here we're going to have a schematic of the arthritic knee being trimmed down to fit the implant going in, bearing surface inserted with its polyethylene, and then you have a nice bearing surface which is constrained based on the conformity of the implant, allowing a good unrestricted range of motion. Well, what's our problem? Well, we didn't always ask the right questions with knees. So there's lots of knees where the surgeon might be satisfied, the x-rays look good, and the patient's not exactly happy. You know, they may say it's better than it was, but not as good as I'd like. And we've changed how we survey now, because instead of just using x-ray criteria and my criteria, we're now starting to use what we call patient-reported outcomes to try to grade and judge how patients are doing. So if your surgeon is asking you to fill out a questionnaire that's asking you how far you can walk, how far you can bend, we're really doing it to get good information about how people's outcome can be judged. We've made a lot of changes. People talk about minimally invasive surgery. We've now been doing these sort of things for at least 15 years. We're trying to make the arthroplasty, the total knee, much more like a sports procedure, like a scope. And by doing that, we're using injections into the knee. We're giving you medicine so that you're not nauseated. We're giving you medicine before you come into surgery. We're using blocks and lots of different things to get you up and moving. And at this point, one can expect that total knees right now are probably 20% outpatient, and over the next couple of years probably will be about 80% outpatient, meaning you're going to come in, have surgery, and go home the same day, right into therapy, like we will treat you like a healthy, active person. We've changed designs of the knee. People have talked about gender-specific knees. They've talked about knees that fit you special. Basically, all of the companies are very good right now. All the materials are very good. They're all made to allow unlimited flexion and have stability through the entire arc of motion. More and more knees right now are being put in without cement. The hope is, if you see the bottom picture on the left, you can see it's like a porous surface. The bone can grow into that. The hope is that the cement, which causes a thermal reaction, it sort of burns things, doesn't cause as much pain. It may not cause as much inflammation, but we are dependent on the bone responding and growing into the implant, and you have to have good solid bone to do it. I think you will notice that it's becoming more and more common because the implant technology has gotten quite a bit better. Hips right now are almost all uncemented. The knees have a bit of a problem with the technology. I get a lot of questions about navigation and robotics, the custom implants. Unfortunately, there's no real custom implants right now. There's a large area of different sizes of implants. We definitely match intraoperative what we're fitting. If you look at the picture on the top left and the next picture over, that's a picture of a navigation device and a study that we did, which shows that when you use navigation, you can narrow the curve of error, even in high volume surgeons. The picture on the bottom right is using a robot. You can see there's a picture of Stryker's robot, and we do have a Stryker robot both in our surgery center and in our hospital. There are other companies that have other robots. I'm not advocating for theirs per se, but what the robot does is it gives you a little bit of option in some patients, not all, where by using a CT scan or MRI, depending on which device you're using, you can use the image ahead of time, link it with the robot or whatever navigation technology you have, and be able to make some small adjustments intraoperatively that are difficult to do manually. Now, high volume surgeons with good experience often can accomplish the same thing on their own, but I think over time we're going to find there's going to be more and more robotic and other technology that enter the operating room to give us a little bit more, more help, so to speak. So we'll talk about hips now. Hips are essentially similar to knees, a little bit different in that it's a ball and socket instead of curved flat on flat. We use the same issues for preoperative care, topicals, anti-inflammatories. Things like hyaluronic acid are not approved by the FDA. You may be offered that, or stem cells, but that's going to actually be a significant economic hit. That's John Charnley. He's an English surgeon. That's his implant, the top left. John Charnley was probably the most significant medical innovator in orthopedics. He was a landmark innovator for total hip arthroplasty. And total hips right now are the most satisfying surgery done and the highest patient impact outside of cardiac surgery, which saves your life, and cataract surgery, which saves your vision and is very rapidly fixed. Total hips are great operations. The vast majority of people are happy. And if it weren't for Sir John Charnley, we wouldn't be doing any of these. We've changed total hips much like we've changed total knees. People talk about MIS hips. Basically, we're able to get in and out of the hip in a much smaller procedures, much less disruption to soft tissues and muscles, much less dissection as we go up and down. There's a fancy picture of a patient with her Blistex on her wound because we just needed a little incision to get in and out of the hip. I wouldn't promise everybody that. How your soft tissues is, how wide your hips are, all matter. Remember, you have to get the ball and socket out. We have to get the implant in. So the larger you are, the tighter your muscle is, the larger incision that we need to do so. There's been a lot of talk about different kinds of incisions. I would tell you, don't worry so much about the incision. Worry about the long-term impact of your hip because we're looking at something to last you 20, 30, or 40 years. This is an example of a mini open. I hope it's not too gross for anyone. That's the head coming out. You can see the head is as big as the incision, so we have to have it big enough to get it out. These are very rapid recovery. They have lots of different ways to do them that we've modified from our old approaches. Direct superior is one that we've been adapting recently, where we're coming in from a little bit more north, protect some of the soft tissue a little bit, a little less stretch on the muscles. But all of them are really, really good. And I got to tell you that your surgeon has tried hard to try to make this an easier experience and a better experience and have a faster recovery. That being said, we have to be careful about what we expect. A lot of talk about direct anterior. This is not a new thing. This is a approach from the 40s. It got rediscovered. It's been applied now for total hips. There are some advantages. There's also some disadvantages. So not everyone is really a good candidate for an anterior. Not everyone is the best fit for it. I don't know that it's better or worse, but you take it all with a grain of salt. Take it all, make sure whoever's doing your surgery has good experience and that they're going to give you the best operation for you. This is just a picture. We have different bearing surfaces. This is a picture. Unfortunately, the video is not playing, but that's a testing machine, and you can see the hip inside that. That'll move, and the companies will test that. That one went for over 5 million cycles and showed very little wear. That's because the implant we're using, the new plastics, are phenomenally better than the old plastics. In teaching residents, you know, when I was a fellow, we used to, almost all of our redos were because the plastics wore out. We hardly ever see that anymore. Our redos are for other things at this point. We're getting a glitch. That being said, what's the problem? Well, if you look at implants, we still do have problems with loosening. We have problems with fractures. Fractures is the most rapid rising problem we're having because people are getting older, their bones getting weak. We still have issues with infection, and we're working hard to try to make those better. Excuse me, something I did want to talk about, because we're in Michigan, is the Markel database. This is the Michigan Arthroplasty Registry. It's a program that we've graciously been funded by Blue Cross. It's a statewide registry. We are becoming the largest registry in the country relative to specific data and being recognized internationally for the quality of the data that we have. Excuse me. Right now in Michigan, we have 72 hospitals, over 300,000 fully abstracted cases. And it lets us get a lot of really good information to make your quality better. Here's some data that we used early on. Here's our unplanned readmissions. These were reported. They're different between the different hospitals. Here's an issue of how many transfusions people were getting over time. There's differences between hospitals. And we know, for example, transfusions are bad. We don't like giving transfusions. So we looked in Marquee and we said, what can we do to make this better? Using this quality registry, using conversations among physicians, we were able to put a quality project in place and very rapidly decrease the rate of transfusion across the state dramatically, save Blue Cross a lot of money, made the patients happier, and really improved the quality. Our goal is to make Michigan the best place to have a joint replacement in the country. Here's some of the other projects we've worked on: readmission projects, ER revisit projects, discharge disposition. We know, as an example, going to a nursing home, which is what people call rehab, going to an inpatient facility after surgery has a dramatic impact on your outcome. We really don't want that to happen. So what we'd rather do is work with you before surgery on managing your healthcare, managing your support system, and try to get you out of the hospital as rapidly as we can, back at your own environment, start some physical therapy, and move forward. The insurers have recognized that, and they're using tools that CORE has designed and implemented ourselves. Our data platform and our quality structure is as good or better than any facility in the country. We're able to decrease complications, we're able to track complications, and we're able to implement changes to your healthcare. So when someone like me is telling you, we need to change your BMI, which is height to weight, I'm not saying you're fat. What I'm saying is, we know based on your health profile that if we start you into a program that's managed to lose weight, if we start you in a program to manage your diabetes and to lower your A1C, if we're able to help you quit smoking, that we can avoid complications that are very predictable. And we would much rather manage those complications on the front end and have you have an excellent outcome from a joint replacement than being chasing tail later on. So good preoperative care, which is conservative, is really, really important to having a good outcome from your surgery. One last thing that we're seeing in the state now is surgeon reporting. This is kept internal, but we're able to report to surgeons where they are comparing to other surgeons. That's me, the yellow dot. So I'm well within a quality measure, below the line actually, where it shows we're trying to get physicians all to be within a quality reported outcome, and we work with them to improve their quality over time. So in short, as we start to get to a close, because I don't want to take too much of your time, be careful with propaganda. The internet has lots of information that is not incorrect. It's quite good to do a little perusal, get some good questions to ask, but listen to your healthcare provider about what the right answers are for you. Joint replacements and conservative care have very good and very reliable outcomes. We have excellent long-term success from total hips and total knees, as long as you've done the healthcare maintenance, managing your comorbidities, and been really set for your surgery. Technology is slow, so don't look for any magic cures, and expect in the future the vast majority of total hip and total knee outcome and procedures are going to be done as an outpatient, whether they be in the hospital and go home the same day, or being done in a surgery center, which has much lower cost for the insurers, and going home the same day from there. With that, I thank you for your time. I appreciate all of your attention. Be careful driving, stay safe, wear your masks, and stay healthy moving forward. We look forward to seeing you in the office. Thank you very much.
Thank you. And now we're going to go ahead and start the Q&A portion of the presentation.
How you're playing tennis now with your bad knee, the hope would be you're playing tennis at least as good with your new knee. Your new knee is not going to take you back to what you used to be. The hope is that you could play tennis as you do now with more comfort. Same question is for golf. And I tell the golfers, we can't improve their game. The pros can't improve their game. But if we do improve their game, then we want to advocate for that. Kneeling is really unpredictable. It's unpredictable with native knees. It's unpredictable with total knees. There's no prohibition about kneeling. It's very hard to tell someone whether they'll kneel comfortably or not. I don't have a total knee, and I don't have comfort when I kneel. So generally, if I'm going to be working on my knees, I got a pair of volleyball knee pads, or I have one of those garden cushions, and that makes my knees not hurt so much. I would say it's the same for total knees. But if you're comfortable kneeling, it's certainly fine. If you have arthritis of your hip and arthritis of the knee, in general, we would fix the hip first. And the reason for that is it is very common for hip arthritis to cause referred knee pain as well. So that's number one. Number two, it's often that your hip is arthritic and we can't fully extend it, which causes you to have a flexion, contracture, or a bent knee. It's hard to get your knee straight. So if we could take the hip out of the picture, it's a little bit easier to focus on those aspects of the knee. And it's also not uncommon if you fix the hip, the patients buy themselves some time because their knee feels better. So I'm going to give you the conservative parts. Generally, the first two, you go home hopefully the same day, if not in the morning. The first 2 weeks are hard. It hurts. We're making you bend across the knee that has just been operated on. You've got some swelling, but the therapist will be helpful. You're on a walker. After about 2 weeks, hopefully you're ready to go into a cane. I like canes. I like walking sticks because I don't like people to fall. From 2 weeks to 6 weeks, that's a very rapid ramp period. You slowly go up. By 6 weeks, we would hope you're walking with or without the cane. Most of your pain is better, hopefully about 80%. And then the next 6 weeks, more rapidly from there. I would say, though, for the ultimate outcome, you have to remember that most people with arthritis have had years and years and years to lose strength, to lose gait patterns, and to get weak. And to go from, boy, my pain is much better, my stability is much better, but I don't feel like I'm quite there. That last bit may take you a year or more, but that's not unlike an athlete. I mean, if you're an athlete and you tear your ACL, it takes you 9 months to get your strength back, and you started out in prime condition. So really the first 6 weeks are the hardest. The next 6 weeks are a ramp period, but we would hope that between 6 weeks and 3 months, you're pretty much where you want to be. Well, it's not unlike the knee. Now, doing a hip injection is a little bit harder because it's harder to hit the joint. So I would say to have a hip injection, you definitely need to have that done under ultrasound or x-ray, which is a bit inconvenient. If you have a hip, I got to tell you, I have a little bit of a bias. I don't like hip joint injections very much. I worry about infection because we're close to the groin. We're going through a very thick, soft tissue mass. But, if you have earlier phase arthritis, having a hip injection with some cortisone, if it works and it lasts you a long time, it certainly can be repeated. Don't want to do it too frequently. But relative to the other compounds, those are not approved for use in the hip. And so I know people do them, but it would be those, you'd have to buy them or figure out some other way to do it. But I don't know that there's any panacea. There's no significant restrictions. I have some basic common sense restrictions. So I'm 80 years old and my hip doesn't hurt anymore. That doesn't mean climb the ladder and get on the roof. I've never skied in my life and I'm going to take up skiing. These are things that commonly lead to falls, and having uncontrolled falls in anybody is a bad thing. It's especially a bad thing around a joint replacement. So I think common sense rules, otherwise do what you tolerate and do what you enjoy. Theoretically, you can. There are several studies done in the early 2000s that showed the safety of that. I would say in my practice, I wouldn't advocate that. I think the medical risks and some other technical issues are problematic. I would say you pick the worst side, you get that done, you know, literally in 2 weeks, if you're doing well, pick a date for the other side. It's also very common that when you get the worst side fixed, your other side may feel better because it's now not having to do all the work. So one of two things will happen with knees or hips. I got the bad side fixed, the worst side. My other side then feels better because I have a good leg to help it, or my other leg can't keep up. Both of those are a very good sign because it means the one you got done is doing well. You then can move forward electively. I'd love to send you home the same day. There's more and more hip replacements being done in outpatient surgery centers where you would definitely go home the same day. Hospitals are catching up with that. But basically, if you get done in the morning, wherever you are, get up and walk on it with the therapist. If you can walk up and down the hall and up and down the stairs, you can go home. But I'm going to say we haven't, excuse me, we haven't really transitioned to our surgery center yet for hips. But I haven't really had a hip, let me rephrase that, probably 85 to 90% of my hips would go home within 24 hours, meaning if they stay overnight, they go home in the morning. Historically, we had something called hip precautions, which for the first 4 to 6 weeks after surgery, we told you, we don't want you to flex your hip more than 90 degrees. We don't want you to rotate your hip in. We don't want you to bring your leg across the midline. All of those were to sort of prevent dislocation, and we've been much, much better about dislocation with all approaches. So relative to protected motion after surgery, coming in from the front, you would protect it one way. Coming in from the back, you'd protect it the other way. With the newer techniques and the different implants, for the most part, that stuff probably doesn't matter very much. That being said, I do think that being attentive to the motions you're doing after surgery often protects the tissue, protects the surgery site, and often helps with pain. So when you're told those things by your therapist or your physician, usually we're only talking about 4 to 6 weeks, and a lot of it is both protective, so you don't do something that is really unsafe, but a lot of it's going to be to help the soft tissue in the surgical site relative to pain and function.